very much for being here. I'd like to apologize prematurely. It's a little difficult to project. So if you have any problems hearing me, or if you would like me to repeat something, just raise your hand and ask me to repeat myself, because I understand it'll be an experience for the both of us to try to get through this without microphone. So I'm going to start off with one of my favorite quotes. People often ask me why I still skydive, but Da Vinci once said, "For once you have tasted flight, you will walk the earth with your eyes turned skywards, for there you have been, and there you will long to return." And that's around 10,000 feet, and you can see Tampa Bay right there, and that's me. So this presentation is titled as a case report, Cervical Arterial Dissection after Skydiving and Neck Cracking, written by myself, Sarah L Hernandez MD MBA, co-written by David Rose MD. The agenda is to discuss first disclaimers, provide an introduction, discuss the case report, provide a discussion, and a short, brief visual of the references. Learning objectives today are to recognize the symptoms of a vertebral artery dissection, and with that information, hopefully differentiate Wallenberg syndrome from a panic attack, as the two, to the untrained eye, can have many symptoms in common. Hopefully you'll be able to understand the rudimentary neuroanatomy behind a cervical arterial dissection. And remember, the panic attacks are a diagnosis of exclusion. Disclaimers: I discovered that there is something called secondary competing interest, and through this, the patient in this case report is myself, and Dr. Rose, the secondary author, was my neurologist. He walked into one of our clinic appointments and he said, "Have you ever just thought about writing this up?" And I said, "I'm ahead of you, I've already completed it. I can email you a copy this afternoon." The breach of confidentiality of the patient, obviously, is done with the patient's consent. So cervical artery dissection. This is important because in the young, which is defined as under the age of 45, up to a quarter of strokes are cervical artery dissections, meaning the anterior cervical circulation with carotid arteries, the posterior cervical circulation with the vertebral arteries. There can be many, many causes, from anything from just standing there to motor vehicle accidents to whiplash, golfing, squash, EGDs, postpartum, skydiving, even just being an orchestral conductor, or just like I said, standing there. One of the biggest causes is chiropractic manipulation. Not many people are dumb enough to do it for themselves, but that's one of the reasons why this case is so rare. There is actually a mnemonic formulated by Dr. Rose for the causes of cervical artery dissection. That mnemonic is called SCAMMERS. It stands for strangulation, chiropractic, accident, moya moya, which basically you don't have good blood flow in your brain, so your brain tries to make collateral blood flow, but the arteries that form are very tiny, and so it looks like on imaging like little puffs of smoke. So that's actually what it means in Japanese. Ehlers-Danlos, which if you remember, that's a type 3 collagen disease, roller coasters, and in this case, a sports injury. So why is this case unique? There are only very few cases on vertebral artery dissection by self-manipulation. In my count, in my research, I've only found 3. And there are no case reports of vertebral artery dissection associated with skydiving. There is only 1 case report of any cervical artery dissection associated with skydiving, and that was a carotid dissection that occurred 4 hours after a skydiving traumatic fall where he broke his femur. They took him to the ER, and immediately the cervical artery dissected. But in this case, the last skydive was over a week ago, about a week and a half ago, and Dr. Rose believes that skydiving is associated with this vertebral artery dissection. So demographics. I was 30 years old at the time, female, I hope that's obvious. skydiver and still a skydiver. And I have a history of migraines, which especially worsened about 12 days prior to the event. We're not associated with skydiving either. I woke up in the middle of the night, the worst headache of my life. Those are the demographics. The event itself occurred immediately after self-manipulation of the neck. Fortunately, I was driving at the time, so I made my way to the nearest parking garage at USF, actually over there. And as soon as I performed the auto manipulation, I experienced nausea, vomiting, hiccups, vertigo, nystagmus, ataxia veering to the right, hoarseness, dysphagia, a right Warner syndrome, and left insensitivity to pain and temperature. Symptoms everybody checked that were completely normal. And by everybody, I mean the EMTs, the ER nurses, the ER primary physician, and what's scariest, the stroke nurses. They all checked only alertness and orientation, strength in four extremities, sensitivity to light touch in all four extremities, speech pronunciation, checking for dysarthria, and reflexes. And guess what? They were all normal. Why are they normal? Well, if you look, these are some of the tracks here. This is actually the cortical spinal tract. If you take this slice here, this is the lateral medulla. And so this is the medulla itself. Shaded in gray, or shaded darker here is lateral medullary territory. And this is light touch, and this is where motor is. This is what was not affected at all. And most people, when they do tests for stroke screening, like EMS and primary ER, they're just testing for motor and light touch, which they're expecting a cortical infarct. And alertness, orientation, that's going to be only in cortical infarcts. So you won't get any of those in brainstem infarcts. And so that was the stroke. So if you look, you can kind of see that this area here is the lateral medulla that you see here, this right here is the whole medulla, and this is the lateral medullary infarct, and this is the medulla here, and this is the lateral medullary infarct there. So they thought I had panic attack because what is a panic attack? We in psychiatry know that it's 4 or more symptoms that reach a peak within 10 minutes. That was uncued, which I had uncued symptoms. And the mnemonic is students fear CCC. I had sweating, trembling, unsteadiness and dizziness, derealization, elevated heart rate, nausea, shortness of breath, and fear of losing control. Why did I fear of losing control? I couldn't walk. I could no longer control my body, could no longer control my voice or my sight. So yes, I was a little frightened. But these are all the symptoms they saw. So when they came to the site, they interpreted it as a panic attack and ignoring the symptoms that actually presented as stroke. So if an EMS person arrives to the scene, or you have a patient who's complaining of a panic attack, how do you differentiate between a Wallenberg syndrome and a panic attack? Well, in my case, and in anyone's case, the biggest difference, the easiest difference that's going to stick out is something you can't fake. The oscillopsia and nystagmus. My eyes were doing this. Dr. Hardy called them crazy eyes because they looked like crazy eyes. An EMT actually came to me in front of her and said, "Stop doing that with your eyes." And Dr. Hardy looked at him like he's crazy, and she said, "She can't stop doing that. It's nystagmus, and it's not voluntary." So in a patient, if a patient has oscillopsia or nystagmus, start to worry, because you will not see oscillopsia or nystagmus in a panic disorder patient or a panic attack patient. Wallenberg, I had ataxia veering to one side. If you have a panic attack patient who has psychosomatic type ataxia, then you're going to see astasia abasia. Now what that is, that's kind of fake falling over, and they're going to fall to both sides. They're going to fall to whichever side they can catch themselves at the last minute on a table or on a person, but they'll magically never fall. Wallenberg, you'll see vomiting, lots and lots of vomiting. Panic attack has nausea, vomiting not so much. Wallenberg, obviously hoarseness. Panic attack, you don't really see hoarseness or change in voice quality. Wallenberg, uncontrollable hiccups. Panic attack, you don't really see hiccups. Wallenberg syndrome, again, there's more than just light touch for sensation. You have your position sense, and you also have spinothalamic tract dysfunction, which is pain and temperature. So check for contralateral spinothalamic tract dysfunction. Pull out your pinpricks, testing for pinpricks. Pull out your vibration fork or your tuning fork. Check for cold. Put it under hot water. Check for hot. If a patient with a panic attack has sensory dysfunction, and if they are quote unquote faking it, you're going to likely see something that's a sensory deficit that's going to bisect directly at the midline, when physiologically you do not see that in a patient, because in reality the nerves cross the midline. So let's say if I had a true sensory deprivation on the left side, I would be able to feel until probably about here, because they cross the midline. If it's Wallenberg, you'll also see ipsilateral facial weakness and numbness, whereas in a panic attack, the patient may instead complain of torso or extremity weakness or numbness. And again, it might not follow a normal dermatome pattern that you would expect. So those are some ways to differentiate Wallenberg and panic attack. The quick and dirty though, look for oscillopsia, look for nystagmus, look for weird things like hoarseness and hiccups. And of course you can smack them with a pin, and if they jump, then of course they can still feel it. Immediate interventions. When EMS arrived on the scene, they interpreted findings as a panic attack, and they gave me oxygen and a chair. Not just any chair, my beach chair, from my trunk. And they sat me down and told me everything was going to be okay. I said, no, it's not. And I was very lucky to have Dr. Cohen on scene, because as you know, she's a resident that just graduated, who is also very, very strong in her neurological knowledge, and she argued on my behalf for them to take me to Tampa General Hospital. No stroke alert was called to prepare for me for my arrival to the hospital. Usually they'll call ahead and call for a stroke alert, but there was none called when I went to the hospital. The ER physician suspected psychiatric hemorrhage and actually overheard her say, I don't know what's going on. But I had Dr. Hartney at that point advocating for my behalf. There was no weakness or dysarthria in me, which are the only signs, the initial signs assessed for or screened for stroke. They assessed the weakness, they assessed light touch and dysarthria, none of which I had. So they automatically assumed I had no stroke. Guys, know your neuro. There are more strokes than just an MCA infarct. So secondary interventions. Dr. Hardy came and held my hand and was my immediate friend there and advocated for me. It was Dr. Hardy, I think, that sped up notifying neurology. And then Dr. Guerrero arrived on scene, who assessed my clinical findings. The MRI brain, I was too acute to have any conclusive findings on the MRI. However, Dr. Guerrero said that if, not based on MRI findings, but my clinical findings were enough for him to convince him to administer TPA. A little late for classical, but definitely within the window for the new criteria for administering TPA. And why it was so scary is that if I didn't have people advocating for me, my chances for recovery would have gone down from 40% to 4%. And so the next day, the repeat MRI confirmed infarction of lateral medullary territory. So, who wants to play Find the Stroke? Any volunteers? I'll give you a hint, it's on the right. Okay, then I'll just tell you. It's right there. So if you look at the left side, this is nice and big and plump and juicy. Now all this is just because it was an off-cut, but this is a flame sign where it's not nice and big and plump and juicy. You see it's very constrained and that is very, very little blood flow getting into my brain, which is now part zombie and liquefactive necrosis. That's the lateral medullary territory right there. It's kind of like the property value in the brainstem, Dr. Rose says, is kind of like South Beach. And any little territory that's infarcted is going to cause a lot of problems. So even though it looks small, it's huge, huge problems. Versus cortical infarcts is like territory in rural Nebraska. You know, you can eat up a lot of space, but maybe not have as bad of symptoms. But I had a South Beach stroke. And because it is posterior inferior cerebellar artery territory, I also had some cerebellar infarct, which was right there. And we can play find the stroke, but I really hope that you guys see it. It's the big humongous white spot right there. And same here in the cerebellum, big white spot. So life in the hospital for a month. I had more teddy bears than a borderline personality disorder patient. I had a lot of visitors. Every day was this new day, but I think everybody, especially here that came and saw me, you guys got me through a pretty rough spot, so thank you. The treatment, they transferred me to Neurology ICU, where I stayed about a week. They provided aspirin and a statin for the stroke, received morphine and tizanidine for the neck pain, which was pretty severe, and gabapentin and clonazepam for oscillopsia. They went up too fast on that, and then one day I got delirious, seeing pink walls that were fluffy, so I consulted Audrey Savino, because I said, they consulted Audrey Savino, who showed up and said, really? But they went, so they finally took out the GABA and the clonazepam. I initially had to have a Dobov tube for dysphagia. It's a very scary thing when you want to try to swallow food and you can't swallow food. I also received collagen injections from ENT for vocal cords for hoarseness. As it's pretty obvious, they have since worn off. And the headache team came by and provided Botox injections for headaches. I received daily PT, OT, and speech, each for 1 hour. The outcome, I stayed in the hospital about a month, got the best view of Gasparilla, although in a wheelchair it could have been more fun. Then I did PT, OT, and speech for another month, an hour each, 3 times a week. Finally, GABA and clonazepam were changed to trihexyphenidyl, which is oral Artane. It's actually very, very good for the dizziness and oscillopsia. Neuro-ophthalmology prescribed that. Returned to work in 2 months. Still have residual dizziness, fatigability, insensitivity, pain, and temperature on the left side, right corners, and obviously hoarseness. I did take advantage of the insensitivity to pain and temperature on the left side and started getting tattoos because I can't feel them. So I'm going to make lemonade out of lemons. So let's talk a little bit more about medullary syndrome. There is a mnemonic, again written by Dr. Rose, called VAST. It stands for the structures affected. The vestibular nucleus will give you, disruptions will give you nystagmus, vomiting, and vertigo. The nucleus ambiguous will give you hiccups, dysphagia, and hoarseness. The sympathetic chain is where you get the ipsilateral Horner syndrome. Disruption of the spinothalamic tract gives you contralateral insensitivity to pain and temperature. Trigeminal disruption gives you ipsilateral facial weakness and numbness, which I don't have. I may have had some of it the first couple of days, but I was kind of out of it. But the important thing is that there are no cognitive side effects because it's brainstem. When neuropsych came and wanted to do full battery of tests, I said no. My cortex is fine. Leave it alone, please. Thank you. So let's go through each of these. Again, this is our little picture of the medulla, and the gray area is shaded for the lateral medulla, which is the infarcted area. That is where the circle area is where the vestibular nucleus is, and again, vestibular nucleus is where you get nystagmus and oscillopsia, vomiting, and vertigo. Now this just shows you, don't have to worry about it because we're psych, but the vestibular nucleus kind of is the interface between the semicircular canals, and the ocular muscles. So vestibular nucleus definitely is the interface between those two and causes the nystagmus. The ambiguous nucleus disruption causes hiccups, dysphagia, and hoarseness. It's ambiguous nucleus, and it causes ambiguous things that are just all kind of weird. The region of the descending sympathetics, you get ipsilateral Horner syndrome. And again, Horner syndrome is ptosis, meiosis, and anhidrosis. And it's interesting because towards the beginning of the day, you can't see it, but come see me at the end of a 16-hour shift on Sunday, and it'll be markedly present. Some of you on night flow have seen when I hand off that key that it's pretty prominent. Spinothalamic tract, you get contralateral insensitivity to pain and temperature, resulting in very comfortable tattoos. And then the trigeminal nucleus disruption, you get ipsilateral facial weakness and numbness. So the important take-home points. Wallenberg syndrome is a common complication of a vertebral artery dissection. And remember, cervical artery dissections comprise of up to 25% of strokes in the young. And the difference is that many of these symptoms can overlap with psychiatric complaints like dizziness, nausea, vertigo, double vision, dysphagia. Strokes comprise of more than just involvement of the motor strip or MCA territory, but a lot of people seem to forget that. Please, please, please keep panic attacks as a diagnosis of exclusion, even if it is in a young female who is a healthcare worker, which we all know are factors in the psychosomatic disorders and are common in people with psychosomatic disorders. Interventions would save my life. Of course, there was Dr. Cohen, who advocated to get me to the hospital from EMS. There's Dr. Hartney, who advocated for rapid involvement of neurology, and Dr. Guerrero, who's also present, who advocated for administration of TPA because of clinical findings, and then Dr. Rose, who took care of me immediately post-stroke and watched me very closely. So the point is that you guys, as psychiatrists, can make a difference. Know your neuro. Know when it's not psych. You know, if you see a patient with panic attack, but they have oscillopsia, that should set off a red flag in your memory and say, hey, I remember that from grand rounds. Get neuro involved. You are going to be the patient's advocate. Because if the stroke nurses don't know what a Wallenberg syndrome is, then someone has to before neurology gets to see the patient. And that someone might just be you. Sometimes clinical diagnosis is all you have to save these patients when MRI might show you nothing. And as a consulting psychiatrist, you yourselves can save a life. So thank you, Drs. Cohen, Hartney, Rose, and Guerrero for saving my life. Here are my references. And this is my first skydive after the stroke. Do you guys have any questions?